So I think we'll start the session today. So we all know that endometrial cancer, the metastatic variant, has got a very poor outcome, and a lot of medications came, but nothing has made a dent in the outcome of these patients. But the recent 5 to 7 years, we are seeing a lot of new medications which got approved, especially the checkpoint inhibitors, either with chemo or in combination with lenvatinib or other target therapies. And the PARP inhibitors are always there, for this specific subgroup. Now, the whole treatment scenario changed after the Cancer Genome Atlas project, where we recognize that endometrial cancer is a heterogeneous group, and the behavior and outcome depends upon what kind of a molecular subclassification we assign to. And on the background of this, we are going to, have a very short and brief, intense session today on unprecedented outcomes in endometrial cancer, advanced endometrial cancers. The session will start with Dr. Aditya Dhanawat, who's a consultant, who's an assistant professor in Tata Memorial. He will be talking about the unmet needs in endometrial cancer, and also this will be followed by today's topic of discussion, ICI in combination with chemotherapy plus minus PARP inhibitors, the DUO-E study, which he will be shedding light upon. So I would like to invite Dr. Aditya. Aditya, hi, you're there?
Yes, hi. Good evening, sir.
Good evening, Aditya. So I think we can start the session. You can, start with your presentation. You can share the screen.
Sure.
Thank you.
So good evening, everyone. Is the screen visible?
Yeah, Aditya, it's visible.
Okay. So the topic of discussion is unmet needs in endometrial cancer and the DUO-E study. So we all are aware about the Globocan data. This is the Globocan 22 from the world, in which endometrial cancer is the sixth most common cancer, approximately 4 lakh new cases and 97,000 deaths. If we look at the Indian data, this is again 22. So Globocan says that in India, although endometrial cancer comes way down as compared to the world figures, however, the number of cases reported new cases are roughly 16,000 and around 6,000 deaths. So there is a heterogeneity and classification of endometrial cancer that Muzammil sir was alluding to. And if we look at, the germline and the somatic mutations that are responsible for the endometrial cancer, one of the most common ones is the, the mismatch repair genes. And so to say, the Lynch syndrome, which is a autosomal dominant syndrome, and it is characterized by the germline mutation in one of the MMR genes. The most common could be MLH1 or MSH2. And we also have seen that there could be co-associated BRCA mutation, but we are yet to establish whether BRCA germline mutation and the risk of endometrial cancer. We can also find some PTEN mutations, and germline PTEN mutations, however rare, they are associated with Cowden, in which we do find breast and endometrium. So quickly revising the FIGO classification, wherein the stage 1, 1A, 1B, 1A being less than 50%, 1B being more than 50%, the stage 2 being invasion into the cervical stroma, but largely limited to the uterus. Stage 3, either to the serosa or to the vagina or to the lymph nodes, and the stage 4, wherein 4A to the bladder or the bowel wall, and 4B the metastatic disease. So there are 4 major molecular subgroups as per the Cancer Genome Atlas, and of which the first one being the polymutated. So polymutated is it's an ultra mutation of the exonuclease domain, and they are highly responsive to the immunotherapy. It has excellent prognosis, followed by the MSI high ones, or so to say the MMR deficient, and they are also highly responsive to the immuno. Followed by the non-specific molecular profile type, wherein the P53 is wild type and they are microsatellite stable. they are not as good as MSI high or the poly mutated. However, they are better than the P53 mutated. And the fourth is the P53 mutated, which are high grade, either serous or clear cell or carcinosarcomas, and they have a poor overall survival. So when we quickly look at the stage and the treatment options that are currently there, so in the stage 1, we go for surgery, and if it is stage 1B, then we offer adjuvant radiation, most likely the vaginal brachytherapy. Stage 2 being again surgery, and then followed by adjuvant radiotherapy. Stage 3 is where we come into the picture, surgery followed by chemoradiation, adjuvant chemotherapy. And then there's stage 4, wherein either if it is surgical debulking is possible, then we go for surgical debulking followed by systemic, or we give systemic therapy if debulking not possible. So when we look at the survival, so stage 1 to stage 2 is roughly 70 to 80% is the 5-year survival. But as we look at the stage 3, stage 4A, which is locally advanced, the survival drops from 75% to 30%. And then stage 4B, wherein it is metastatic, debulking is not possible, the survival drops to 17% by 5 years. Similarly, the stage 4 is at the highest risk of recurrence. And at present, the first line standard of care for deficient MMR stage 4 is chemotherapy plus IO due to multiple phase 3 data that came out in 2023. And prior to 23, it was only and only chemotherapy. Now we have newer drugs in the block where we are going to discuss about. So quickly coming to the topic, which is the DUO-E study. It was durvalumab plus carboplatin paclitaxel followed by maintenance durvalumab with or without olaparib in the first line advanced or recurrent endometrial cancer. So the background of the study is that tumors could be either a hot tumor or a cold tumor based on the immunogenic properties. So hot tumor responds to immunotherapy drug well because it has immunogenic and microenvironment. It has T cells which have high PD-L1 expression, or they have T cells which respond to the immunotherapy because of the immune mediated the process by which the cancer cells inactivate the T cells. They are efficiently blocked by the immunotherapy. And then there are cold tumors in which it is a non-immunogenic tumor microenvironment, and cold tumors may not respond well to immunotherapy drug. So when we look at immunotherapy and the endometrial cancer, so there is deficient MMR and proficient MMR, two distinct cohorts. And when we look at deficient MMR, so chemotherapy plus durvalumab, so there is direct tumor cell killing by the chemotherapy, and then there is an enhanced immune response because of blocking between the PD-1, PD-L1 interaction by durvalumab. And then you look at the proficient MMR, in which in proficient MMR, although the PD-L1 blockade is limited, still it is one of the treatment option. So what is the rationale behind combination of durvalumab and olaparib? So there is something known as a STING pathway in activation, and by the activation of STING, there are certain cytokines and chemoreceptors which get activated and help in additional killing. So this diagrammatic representation is basically on the activation of STING and the release of the T helper cell 1 cytokines. And these cytokines again recruit further T cells for the anti-tumor immune response. So basically there was two phases. One is the induction phase and the maintenance phase. The induction phase being the platinum chemotherapy plus durvalumab, and then there is a maintenance phase wherein there is durvalumab or durvalumab plus olaparib. So this study was basically for newly diagnosed stage 3 or stage 4 or in the recurrent endometrial cancer. And patients were prior known whether they were MMR deficient or proficient, and they were stratified accordingly. They were naive to first line systemic therapy. They were naive to PARP inhibitors or immune therapy. Patients who had received prior adjuvant therapy were allowed if the duration was more than 12 months, and all histologies were included except sarcomas. So the chemotherapy phase was paclitaxel, carboplatin 3 weekly, and there were 3 arms. So first arm was chemotherapy alone. Then in the second arm, it was chemotherapy plus durvalumab. First, initially, while the chemo was ongoing, it was 3 weekly, 1120 mg, followed by maintenance, in which it was 4 weekly, 1500 mg. And in the third arm, it was again chemotherapy plus durvalumab, but in the maintenance, it was durva plus olaparib. And the investigators looked at the progression-free survival as the primary endpoint and OS and safety as the secondary endpoint. So patient characteristics were pretty well balanced between the 3 groups: chemo plus durva, chemo plus durva plus olaparib. If you look at the geographical regions, so roughly 28-29% were Asians. So to say, a good number of Asian patients. And the other thing to note is, so in the stage, if you look at the stage 3, there were around 5% patients, whereas stage 4 were roughly 40% patients in the newly diagnosed, whereas there were 50% who were recurrent endometrial cancers. And when you look at the MMR proficient and deficient, so roughly 80% were proficient and 20% was deficient. Again, it was well balanced between the 3 groups. And the other thing was, when we look at the histological subtype, the most common being endometrioid, followed by serous. So quickly divulging into the progression-free survival, which was the primary endpoint. So the 1-year PFS was 61% in the chemo plus durva plus ola arm, followed by 48% in the chemo plus durva arm, and then 41% in the chemo arm. So if you look at the hazard ratio, when you compare with the chemo only arm, so durva arm had 0.71, so 29% reduction in progression. And if you look at durva plus olaparib arm, roughly 45% reduction in progression with the hazard ratio of 0.55. And as we speak, the data maturity was 61%. We do have some initial OS data also available, in which the 18-month OS was 79% with the durva plus olaparib, followed by 74% in the durva arm, and then 69% in the chemo arm. So if you compare the percentage between the chemo versus the durva plus olaparib, so roughly 10% being the survival difference at the 18 months. So when we do a subgroup analysis and we see by MMR, so the deficient MMR, which was 20% of the population, the hazard ratio in the durva arm was 0.42. And when you look at durva plus olaparib arm, it was 0.41. So pretty good data showing that in the deficient MMR, the drug has definitely helped. Both the drugs have definitely helped in improving the PFS. In the proficient MMR population, which is 80% of the population, again, the hazard ratio for durva alone was 0.77, whereas for durva plus olaparib, this was 0.57. So if you again closely look at the hazard ratio difference between the durva versus the durva plus olaparib, it was 0.76. So the doublet working better than durva alone. If you look at the proficient MMR population and what was the response rates, so the doublet arm, which was durva plus olaparib, had a 15% CR as compared to 8.8% in the durva and 9.6% in the chemo arm. However, the total percentage of patients who had a complete or a partial response was by and large same in the chemo or chemo plus durva, and slightly higher in the durva plus olaparib arm. Again, when you look at the OS data, as per the MMR status, so deficient MMR having a hazard ratio pretty impressive at 0.34 for durvalumab and 0.28 for durva plus olaparib. And when you look at the proficient MMR, the OS data not very exciting for durva alone in the proficient MMR status. But when you see durva plus olaparib, again, the hazard ratio is good at 0.69. But we need to wait for the median OS. This is according to the PDL1 status. Again, looking at the PD-L1 positive population, the hazard ratios being favoring the durva plus olaparib followed by durvalumab. And if you look at the PD-L1 negative population, hazard ratio being 0.8, but it crosses unity. And again, for durva alone, it was 0.89 crossing unity. So this is the forest plot, which says that based on, if you look at the PDL1 positive, that is one good cohort. If you look at others, they are crossing unity by and large, but hazard ratios being less than 1. So one important thing that we need to talk about is the safety. So if you look at the grade 3 or more adverse events, so grade 3 more or more adverse events was more in the durva plus olaparib arm in the overall phase. So 67% versus 55 to 56%. So roughly 10 to 11% more grade 3 or more adverse events, of which the most significant one is the anemia. So you see the rates of anemia being roughly grade 3 or more, anemia being 8% or more. And so far, there were no cases of MDS or secondary AML. And if you look at the drug discontinuation, it was 18% in chemo, 21% in durva, and 24% in durva plus olaparib. The other thing to see is in the maintenance phase, if you look at the rates of anemia, so anemia rates with chemo arm is 0.6%, whereas with the chemo plus durva plus olaparib, the grade 3 or more anemia was 18%. So this is something that we need to look at, that when we are giving patients olaparib plus durva in the maintenance setting, grade 3 or more anemia is something to be wary about. So again, these are the all adverse events grade 3 or more, which were more than 5%. So there was neutropenia, anemia, thrombocytopenia. Also, there was a significant increase in fatigue, which was roughly 5%. And there were some cases of pure red cell aplasia, but thankfully no MDS or secondary AML. So when we look at the discontinuations, so the discontinuation rates was about 24% in the durva plus olaparib arm, and dose interruption or delay was seen in roughly 68%, whereas 54% in the durvalumab, and dose reduction of olaparib was required by roughly 27% patients. So this is something that we know that in our practice also, olaparib is a slightly difficult drug to handle. So we need to be aware about the adverse event that may happen, and so to say, be preempt about dose reduction. So to summarize, the study met both the primary endpoints. Both the chemo plus durva and chemo plus durva plus olaparib had significant improvement in PFS. Interim OS data looks interesting, especially in the deficient MMR status cohort, and there is a positive trend towards OS. We need to wait for the data maturity to see the medians. The other thing is chemo plus durva reduces the risk of progression or death by 58% as compared to chemo only in the deficient MMR population. And that is a good area where we should definitely plan to give the drug. The combination, it further improves the outcome in the proficient MMR and has a median PFS of roughly 15 months and reduces risk of progression by 43%. Safety was consistent with the known profiles of each individual drug. Thank you.
Thank you, Aditya, for that, very elaborate discussion and covering of the DOE trial very well. Now we can invite the next speaker, Dr. Darshit Shah. He will be talking and helping us in integrating the immunotherapy and target therapy. Darshit, over to you.
So thank you very much. Thank you, Aditya, for the insightful talk. If somebody can share the slides, the organizing team.
Sure, sir.
Sure. So good evening, everyone. I will be discussing regarding the integrating immunotherapy and targeted therapy in endometrial carcinoma. Next, please. Systemic therapy in endometrial carcinoma. Next. 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 Correct. So we all are aware that endometrial carcinoma, the NCCN recommendation category one is chemoradiotherapy when cisplatin followed by cisplatin plus RT or paclitaxel with RT is one of the recommendation. For systemic therapy, we have three or four options. We have paclitaxel and pembrolizumab as the first line therapy for stage 3 and 4 tumors except for carcinomas. Second is paclitaxel. The other option is paclitaxel durvalumab in stage 3 and 4 deficient MMR tumors only. And if the patient is HER2 positive, then we can definitely add trastuzumab. Next, please. So when it comes to recurrent disease, we do have paclitaxel pembro as a preferred regimen if the patient has not received IO in the first line. The similar options are paclitaxel dostarlimab or durvalumab deficient MMR tumors. And based on the HER2 status, we can add HER2 positive, HER2 targeted therapies like trastuzumab, or I may be more tempted toward trastuzumab and HER2 both. Next, please. Next. So these are the guidelines, the ESMO and ESGO guidelines in the stage 3 and 4 or recurrent endometrial carcinomas with no prior chemotherapy. These are the guidelines in which MMR deficient tumors, we give chemotherapy plus ICI in combination followed by ICI as maintenance therapy. If the patients are not having MMR deficient tumors, then we just look at the symptomatic advanced disease or rapidly growing disease. If chemotherapy is usually the first choice, the addition of immunotherapy to chemotherapy is also one of the options, followed by IO maintenance. If chemotherapy is contraindicated, then we have limited options. We can consider pembro and lenva. In patients who are low grade, ER positive, low volume asymptomatic disease, we may consider endocrine therapy. Next, please. Yes. So, the second line systemic therapy is in unresectable recurrent disease, after platinum based therapy. So, first and the foremost question is, were ICI as a part of initial therapy. So if immunotherapies were not given prior, we definitely should consider immunotherapy in the second line therapy. If MMR deficient tumors, we can consider pembro monotherapy, or we may also consider pembro plus lenva. If it's non-MMR deficient, still we can consider pembro lenva as the second line of therapy. If the immunotherapies were a part of initial therapy, then we have only options of chemotherapy, that is paclitaxel or doxorubicin or any other form of chemotherapy. Next, please. So the combination IO therapy is now the established as second line standard of care in advanced endometrial carcinoma. Next, please. So IO is definitely changing in the second line advanced endometrial carcinoma landscape with monotherapy and the combination approval. It started with Keynote 158 in 2015, where pembrolizumab was the first indicated. After that, we have so many immunotherapies, dostarlimab. Now we have durvalumab. So we have plenty of options to choose from. Next page. So speaking about the Keynote 775 study, it was an investigated second line plus platinum-based chemotherapy in patients, uh, platinum-based chemotherapy versus pembrolizumab in patients with advanced endometrial carcinoma. So basically, they were stage 3 and stage 4 recurrent metastatic endometrial carcinomas. They were randomized into two arms. One arm was pembro plus lenva, 20 milligram up to 24 months. The other arm was chemotherapy. Next, please. So it definitely demonstrated the superior efficacy of second-line pembro plus lenva in patients with advanced endometrial carcinoma, and in patients who have MMR proficient or tumors, the benefit was there overall study. So we can see that the tolerance also was very pretty much fair with pembrolizumab. Grade 3 adverse effects definitely being hypertension being one of the adverse effects for lenvatinib was seen in majority of the patients, but otherwise neutropenia, anemia, and weight loss were also seen. But every major side effects were manageable. The most serious side effects were hypertension, which occurred in 4.2% of patients with pembrol and lenva. And the dreaded side effect with chemotherapy is febrile neutropenia. Next, please. So, establishing combination plus immunotherapy as a first line standard of care in advanced metastatic or recurrent endometrial carcinomas. Next, please.
Darshit, you are muted.
Sorry.
Yeah.
Next, please. Next, please. So yes, so the NRG GY018 met its primary endpoint of improved PFS with pembro with chemotherapy versus standard of care chemotherapy will greatest benefit in the MMR deficient population. We can see that the plot is the curves are widely separated as early as 4 or 5 months, and the separation remains persistent throughout. We can see that the PFS was not reached in the pembro plus chemo arm versus placebo plus chemo, it was only 7 months. So definitely in MMR deficient tumor, there is no doubt pembro plus chemo is one of the major recommendations. When we talk about MMR proficient tumors, also the benefit was there with pembro plus chemo, although the quantum of benefit was lesser as compared to deficient tumor, and it was like 13.1 versus 8.7 months. When we talk about the safety, it was very well tolerated, and no new signals, no new safety concerns were reported apart from the usual side effects which we see with chemotherapy and pembrolizumab. Next, please. Moving on to the Ruby Part 1 study, which investigates the combination of dostarlimab with chemotherapy in patients with recurrent or primary advanced stage 3 or 4 endometrial carcinomas. So here the two arms are, one arm is dostarlimab 500 milligram plus paclitaxel every 3 weekly for 6 cycles, maintained by dostarlimab maintenance. The other arm is chemotherapy. The primary endpoints are progression-free survival and overall survival. They are stratified by stage 3, stage 4, MMS status, and prior pelvic radiotherapy. Next, please. So the interim analysis shows that the dostarlimab group is, is better as compared to the placebo group at 24 months. The PFS is double, like 18.1 versus 36%. So it is definitely superior as compared to chemotherapy alone. When we talk about MMR deficient tumor, definitely dostarlimab is far superior as compared to the placebo group. And overall, the study was the tolerance was very uh, decent, and there were no major side effects apart from fatigue, nausea in the chemotherapy arm. Next, please. So this is the dostarlimab plus chemotherapy showed statistically and relevant OS in overall population compared to chemotherapy alone, but definitely a substantial and clinically relevant survival difference was seen in MMR deficient MSI high population, with the median OS improved by 7 months with a 21% risk reduction in the risk of death. The Ruby Part 2 met its primary endpoint by demonstrating a statistically significant PFS improvement in patients receiving dostarlimab plus chemotherapy, followed by dostarlimab plus niraparib versus chemotherapy in both overall and MMR proficient population. And the safety profile observed was generally consistent with the known safety profiles of individual agents. Next, please. So, speaking about NGOT, the eligible patients are stage 3, stage 4, all histologies except sarcomas, and then the patients are naive to systemic anti-cancer therapy or had a recurrence more than 6 months. The two arms were dostarlimab plus chemotherapy in one arm, and the other arm was chemotherapy. They was given for 6 weeks, followed by dostarlimab 1000 milligram every 6 weekly up to 3 years. The primary endpoints was PFS and overall and by RECIST criteria. Next, please. So we can see that PFS from the DOE and Ruby to intention treat population in MMR proficient and MMR deficient tumor. We can see that in MMR deficient tumor, it was DOE had a PFS of 31.8, whereas in Ruby part 2, it was not reached till now. In MMR proficient tumors, we can see that both are similar. It was 15 months in the DOE. In the Ruby part 2, it was 14.3. Next, please. So the DOE study, we can see that the standard of care plus durvalumab, the hazard ratio is 0.42. It's very impressive hazard ratio, although the addition of olaparib was not was did not achieve a significant meaningful improvement in the PFS. When we talk about the Ruby part 1, it's still investigational and we will be having the data soon. But overall, if we interpret from this that durvalumab plus chemotherapy definitely has significant advantage in patients who are MMR deficient tumors. Ruby Part 1 also it showed dostarlimab addition with chemotherapy also had significant responses and there were sustained responses. When we talk about NRG GY018, we can see the pembro plus chemotherapy also had significant sustained meaningful responses as against chemotherapy. And also the other trial attend it also is showing similar results. Next, please. So the difficult to treat are the carcinosarcoma. We can see that Ruby and got ENC, NGOC, NSGO trial. We can see that dostarlimab, it was like 10.2% versus placebo 7.6%. In the DOE study, it was like 5% in durvalumab arm versus placebo, it was 8.7%. So the PFS was more than 6 months in dostarlimab arm, and in also in the pembrolizumab arm, it was more than 12 months. So the duration of maintenance in this Ruby study was 3 years until or disease progression. In the NRG GY018, it was 2 year or until disease progression. With atezolizumab, it was until disease progression, and the DOE studies also until disease progression. So overall, in MMR deficient tumors, the addition of chemotherapy with dostarlimab, with pembrolizumab, or with durvalumab, it is showing similar outcomes, but it is definitely far superior than chemotherapy alone. Next, please. With this, I would like to conclude. Thank you so much for giving me the opportunity, and thank you everyone for patience listening.
Thank you, Darshit, for an excellent coverage of the entire treatment options which we have today at our disposal. And with this, I would like to invite my panelist for the next panel discussion on management of endometrial cancer, advanced metastatic cancer. I would like to invite Dr. Tejinder Singh, Dr. Shivam, Dr. Anuradha, Dr. Vaibhav Chaudhary, Dr. Aditya Dhanawat, and Dr. Darshit will continue. So, can someone share my slide meanwhile? So I think we have moved from the era of just chemotherapy to an era of having lot many options for treating patients of metastatic endometrial cancers. And with moving logically from the second line now to the front line with the data which just Darshit presented, I think there is some, food for thought for all of us when you're going to practice patients in clinics tomorrow, with the type of options we have. Next slide, please. So this is the case, a 63-year-old female presented with postmenopausal bleeding in April 2022, and the USG abdomen showed a thickened endometrium. MRI showed a thickening on the endometrial mucosa at the fundus. It was less than half of the myometrial thickness. The biopsy was a model differentiated high-grade tumor. Underwent Vardheim cystectomy in April 2022. Next slide. And the histopath was a 3.5 into 2.5 centimeter tumor, involves more than half of the myometrial thickness, node negative, no LVSI, and grade 1. It was FIGO stage T1B N0. Next slide. So I think this part we will skip this slide because it's all purely surgical, which we are not going to waste time on. There is no surgeon in the panel. Next slide. Next slide, please. So we will just run through, this was an early stage at this juncture when we are discussing, but nevertheless, we'll just recapitulate for our benefit the factors which are important in deciding the treatment in endometrium. Next slide. So, of course, we know the type of histology we are dealing with, aggressive versus non-aggressive histology, and this we are talking more about metastatic endometrial cancer now. So, non-aggressive histology, advanced diseases, we still can have hormonal therapy as one of the options, especially if the patient is elderly, frail. Either the megestrol or medroxyprogesterone can be chosen, and based on the aggressive histology, we have now various options. Next one. The depth of myometrial invasion, more so important for the earlier stage of disease. Next. The grade is very important. Based on this grade, we decide treatment in adjuvant treatment in early endometrial cancers. Especially now we have enough data stage 1A, and we try to avoid any radiation therapy, grade 1 and grade 2. Stage 1A, grade 3, there is some data, convincing data to add radiation, which is brachy, and stage 1B onwards, we do add brachytherapy in this subgroup. Stage 2 beyond, obviously, radiation, which Aditya has covered. Next one. The LVI is very important, whether it is a focal or an extensive or substantial LVI as they define, more than 5 vessels involved. Next slide. Next slide, please. And macrometastasis, which is obviously important. Next one. Cervical stroma involvement is also a risk factor for recurrence, where radiation is recommended. Next slide. And the major impact what's happened now is with the cancer genome atlas data coming up. Now we have subdivided endometrial cancer into subgroups, mainly the 4 subtypes, and the Transpotec or the Protect trials, the Rainbow trials are still in pipeline. We'll get the more information in coming years. Next slide. And the stage of the disease. Next one. Yeah, next one. So she underwent brachytherapy and was followed up till May, and in July 2023. Next slide. This will skip. Again, we don't have a radiation oncologist here. Next one. Next slide. So I think most of us are giving concurrent cisplatinum. Any panelist differing in the type of concurrent regimen they're offering or experience with anything? Tejinder, your take on concurrent chemo?
No, cisplatin. I think previously the slide which you have presented about the risk stratification. Now we are moving towards a molecular risk stratification. Now ESMO has totally change the risk stratification or guidelines into pole, DMMR, and your NMMR, basically non-specific MMR. So into that, so more than the other risk categories like LVSI and other thing, and they have also included one more is substantial LVSI. Simple LVSI has got no meaning,
Correct.
and a substantial LVSI where more than 4 LVSI are seen, they have got importance. Pathologists should not report only LVSI. So what you said is very right. Cisplatin is the one which we normally use it. That's the most
I
common.
think most of the panelists will agree to that. This now, Shivam, do we really are doing or getting the reports which are sub-classified, or we are asking, meaning are
Sir,
the labs equipped now?
Sir, I think our pathology department is giving P53 now as a standard, and MSI they are doing. Now, based upon the other risk factors, I'm asking the patients to do a pole mutation, but P53 and MSI, sir, now they are, at least our pathology department is giving.
Vaibhav, your take, should it be done in what way? Meaning, what will be ideal for?
Yeah, I think as we are adopting very fast, so I think we should go for the full if some endometrial panel is there, but with the limitations and the hospital adopting thing, I think P53 is a must, MMR is a must, and pole, yes, that is required. So this
Anuradha,
is
at Tata Memorial, you are doing this poll in all patients, or you super select some patient?
So for stage 2, we are doing in all who are P53 mutant and MMR proficient to downstage them. For 1A we are not doing, and for 3 and 4 we are not doing.
Yeah,
Correct. Next.
Muzammil, I think Anuradha said very right.
Correct.
Ideally, P53 is more useful, and there are some sub-classifiers also. Like if P53 comes with DMMR becomes more prominent. If P53 comes with your pole becomes more important. But that is only for stage 1 and 2. Stage
Correct.
3 and 4, they don't have any importance. It's very clear that you have to go for the standard therapy. And if the histology is serous or carcinosarcoma, then also all this molecular profiling have got no use.
Fantastic. So I think the message is very clear. The histology also dominates the treatment plan, of course, from the stage. Next slide, please. So unfortunately, this case relapsed. So she had abdominal pain and right leg swelling. The PET scan did show a conglomerate right common iliac, iliac nodes, and FDG avid intraperitoneal soft tissue. Next slide. This PET scan does show no, recurrence which is beyond surgical amenable, looks like. Next. So the question is that when do you test for molecular markers? At diagnosis, after the surgery, hysterectomy, or after the relapse, the biopsy? And the second question of the same is that do you repeat molecular testing if the patient has done at the beginning, whichever timeline you have chosen from above? When the patient progresses, do you repeat molecular testing? We can start with Aditya first.
Yes, sir. So we should repeat molecular testing on progression. So essentially ER, HER2 and MMR on the block that we can do.
And what is the timeline when you will do the first molecular?
The first molecular, like we are doing on diagnosis, we are doing MMR and P53 for the and those who are P53 mutated, I think that is enough. So P53 MMR and yes, if they are high grade, then we should do HER2 also.
Correct. Vaibhav, your take on this?
most similar things, sir. At diagnosis, this much is sufficient. What Aditya told.
Correct.
Rest of the things come into play later on at the relapse, and yes, we should actually repeat molecular testing on progression. Yeah.
Next slide, please. So this patient underwent a lymph node biopsy, which was serous high-grade adenocarcinoma. Next. So I think this we have already discussed that, which test you would like to do in a patient of endometrial cancer. Still, for the benefit, Darshit, can you elaborate which one you will prefer to do, or anything else from apart from this? Darshit, we have you on line.
Muzammil, this is a metastatic case, right?
Correct. Metastatic.
Honestly, in metastatic, there is
Why
no
for
role of pole,
yeah.
pole P53 and other thing. Even
This for
PDL1 has
adjuvant.
got no. In a metastatic, it has got only thing which is going to helpful is
DMMR.
is MMR status, HER2, very important. A second thing is that uterine serous is different from the ovarian serous. Huh?
Right.
Uterine serous, the behavior is different from the ovarian serous. Second thing is HER2 is very important. Around 20-30% uterine serous will come positive. And on the hormone status, PDL1, to my knowledge, has got no use in the metastatic setting.
Correct. So some PDL1 benefit if you're doing a subset analysis, honestly, for, in a proficient subgroup, if we're going to use a PARP inhibitor, all those data is churning, it will come up. But, I agree with Tejinder. And the entire panel actually agrees. The type of molecular test which we want, at presentation what we want, and at metastatic, if the patient is presenting, only, MMR is something which is more relevant apart from HER2. Next slide, please. And which is the method, Vaibhav? We are using which one? ISC, NGS? What is your
I would
preference?
go for NGS and I would go for a broad panel, most probably if feasible, then CGP. There are reasons I know that doing less sometimes will can be good, but for relapse which has happened and fast and these patients hardly give time. So we should get the complete information because there are many things. I agree that HER2 is important, definite MRI important, whatever trials are there, they stratify on this. But in my practice also, whenever I have resorted to NGS, there are certain other outlier mutations also. Like I was lucky enough to find one NTRK in a heavily metastatic. So why to lose that and keep it for later? When we are doing a proper test, I think in one go we should do a proper CGP. That's what my personal take is, that it's driven by personal practice.
Shivam, you will do a broad panel or you will do a limited?
So as of now, I'm doing IHC. I'm just looking for HER2 and MSI. So that is IHC based. And if these two are negative on further progression, and then I call the sample back and then send for CGP. So I don't think my primary decision changes with the CGP. My primary decision would remain same practically.
Aditya, your take? A broad panel or?
Sir, I'd put it on patient feasibility because many of our patients are not feasible for it. So at least ERPR, HER2, and MMR, I would do on the IHC. If they are negative, if patient is feasible, then I would go for a NGS. And as rightly said, ki NTRK is one of the mutations that we see. And so if patient is feasible, then yes, should go for NGS.
So I think the panel more or less agrees on this part also that, we have ISC which can suffice in most of the cases, but yes, you should discuss with patient if they're affording, why to miss in a very rare mutant where there can be therapy which can be effective. Next slide, please. So this actually we have seen in many, presentations, the way the things are, how they're tested today. We will just skip this for benefit of time. Next slide. And this again we have seen, we know that only 5% to sometimes 15% are pole mutant, 20-25% is MSI in clinical practice, and TP53 mutant are around 30%. When based on what kind of molecular subtype you have, we can have a outcome prognosis. The OS is very clearly depicted in this cartoon, where P53 is the worst outcome and pole hypermutated is the best outcome. Next slide. So on ISC, this patient has a P53 mutation, ERPR positive, HER2 negative, and MSI stable. Next slide. And these are the same subgroup. They have tried to give some features, additional features. We will not go in details of that. We have gone through this many times. Next slide. Next slide, please. So what is the current line of management in deficient and proficient MMR advanced endometrial cancer? I'm talking about the front line or the first line and maintenance, and anyone, talking about the role of cytoreductive surgery in HIPAC and HIPAC. So we can start this with Anuradha. You can take this one, your choice of first line.
So for DMMR, we are offering IO with chemotherapy, which is a taxane with platinum combination. And in a very frail old lady, as was discussed in the talk, and a hormone receptor positive patient, not very symptomatic, we offer hormone therapy. And in PMMR, we discuss IO option also based on that Keynote of OS updated analysis. But that standard remains paclitaxel and carboplatin only, plus minus immunotherapy. And our choice is currently pembrolizumab because of the higher clinical experience. Just that.
And any role of, if they respond well, secondary cytological surgery and HIPEC you're doing in this advanced diseases?
So, sir, there is some role of debulking. There is no OS benefit as such of debulking surgery in stage 4 also, for symptomatic benefit also. And we also offer salvage RT to such patients if they are extremely symptomatic.
But then you select out your patient. Very few will get this.
Yes, sir.
Tejinder, your take?
No, I think Anuradha summarized very well about the status of DMMR, PMMR. Most of us follow the same concept. Both DOE has given us a advantage of utilizing. This is one of the only malignancy where on the PMMR also you can think about giving chemo plus durva also. But secondary cytoreductive surgery in selected few, and also the role of radiation is also in the selected few.
Any taker for an elderly patient who is, frail, who is ER negative, will you go for a single agent immuno? If this is
So, single agent, if the patient is DMMR, I might think about it also. Single agent.
Correct. Because it is already approved in the second line. I think if the patient is not fit, we have enough data to, try
there's
to...
a data for the DOSTAR also. Very good data for the DOSTAR, especially for the DMMR in endometrial.
So I think a deficient patient, I think even elderly frontline single agent can be an option for them.
DOSTAR works very well.
Yes. Tejinder, any cytoreductive surgery, HIPEC for this stage 3, 4?
So HIPEC, I will say it's selective few, not too much. Like I think Anuradha was also very clear that only selective few. I had done it for only 2 or 3 patients, but a lot of discussion needs to be done for this patient.
Shivam, your take on this?
Sir, I agree with the co-panelists, Dr. Tejinder and Dr. Anuradha, for the PMMR, DMMR status. Debulking surgery, yes, if the PFS is good from the previous treatment, and I don't offer radiation to the patients until pain management is.
Yeah, same here. Radiation, we are not using. It become an obsolete now with the immune therapy and all, we are not using. Aditya, any take on the radiation part?
No, sir, I completely agree, sir. Salvage RT we have given, but that is very selected patients, and only if patient is symptomatic, no advantage as such on the survival as such.
So one patient had, endometrium and then had a large recurrence in the node, neck node. That is where we have used RT apart from few nodes in the abdomen, but we radiated the larger mass. And this patient has done well. Currently, she is on one of those Chinese immunotherapy drugs and doing well. So I think you individualize the cases basically. Next slide. Next slide, please. Next slide. Next slide. So this all already, Darshit has covered in detail. We will not go through this. What is the current treatment plan for carcinosarcoma? Anuradha, frontline, what are you giving? Metastatic disease.
Sir, doublet chemo only, sir.
No takers for immunotherapy, even if the PD-L1 is high, suppose. I think no one answered, so I got my answer. Next slide, please. So I think DOE was already covered by Aditya in detail. We'll just, skip few slides for the benefit of the time here. Next slide. Next slide. We have all gone through all these details. Next slide. Next slide. Next slide, please. Yeah, one slide before you can go. So will this impact your clinical practice, whether the patient is deficient or proficient, and after this current data? I think most of us are agreeing to this, that if finance is not an issue in a metastatic disease today, even a frontline patient, we will prefer to start a combination of, immuno with chemotherapy. Now the whole discussion is that which is the group of patient where you will consider PARP inhibitors. We can start with Shivam as a maintenance, doublet maintenance.
So now the DOE data, I need to look at it. PARP inhibitor should come in all patients, even with Dosara there is Nira, and for this there is Ola. So I will have to reconsider, sir. Upfront, I
Vaib-
was not giving to any patient until they were BRCA positive. But now I will start looking into it.
Vaibhav, your take?
Yeah, actually for
Whom will you?
deficient MMR, I don't see any from the data also. There was not even an additive advantage of adding olaparib, forget about synergistic. So for deficient MMR, I think single maintenance with the immunotherapy would be good enough. But for proficient, yes, it has some positive signal. It has additive effect, if someone can say. And if you look at the three arms of DOE, there was, I don't think there was a formal comparison between the combination of maintenance of this Durva plus olaparib versus the arm of Durva. All the comparison was with the chemotherapy arm. So that answer actually remains how much the olaparib is adding. But yes, looking at the numbers and all, definitely there is some value. Whether that value is synergistic or additive, that needs to be seen. But I
We'll
would give
ask
it.
we'll ask
Yeah.
the organizers today to share the data of there was some analysis of Durva versus Durva with Ola in the
Mhm.
PFS. So we'll ask them to share with us. Sophia, just ensure that they share these slides also. Okay. Now, Anuradha, your take, which patient you will go for olaparib maintenance along with Durva?
So, sir, in PMMR patients, that benefit of olaparib seems good, but that just that the OS is trending towards benefit, but still that data is pending to matlab we'll be seeing more of it. And the post hoc analysis which they did on PMMR subgroup, they showed that more than 80% of that patient had some or the other biomarker positivity. 8% of them were BRCA positive, some had HRR, and PDL1 was also positive in more than 50%, around 60% had that also. And irrespective of those biomarkers, there was benefit with the olaparib and Durva in the PMMR in the cohort. So still now, sir, we are not very convinced that we'll be changing practice very soon based on only the DOE data. But we'll wait for the OS data maybe to finally change practice, I think.
Why do you think there was a benefit? I mean, this is very contradictory to my expectation. I was expecting the PARP inhibitor to do well even in the deficient one, but there was no clear,
Yeah.
no benefit at all
No benefit
whatsoever.
at all.
So I think we're still, learning this. Quite a few were, TP53 positive also in this proficient MMR subgroup in the molecular analysis, apart from
Yeah, they
PDL1
would have
and
responded.
correct. So I think we still need to see this data, but I don't know. Tomorrow, if a patient comes with this and there is data, this is a good trial. Maybe if the patient is tolerating also well, maybe I will be tempted to add a PARP inhibitor in maintenance along with Durva.
Yeah, I think,
Uh,
sir, when we go ahead and see the patient's journey over 6 cycles of chemotherapy, and when you decide about maintenance, you get a good idea about patient's tolerance, even to olaparib. All said and done, olaparib also has a significant amount of hematotoxicity. So I think at that point of time, you should actually choose, and you are in a better condition to choose rather than upfront, which patient would actually benefit with a combination.
Correct.
Uh,
Aditya, your take?
I have a couple of points to make. So in the deficient MMR, yes, we can get away with durvalumab alone. In the proficient MMR, adding olaparib does help, but then keeping in mind the 20-25% risk of grade 3 anemia, that was significant in this study. And I'm definitely sure that our rates of grade 3 anemia would be possibly more than that which has been reported in the study. The second thing is regarding self-paying patients, it's okay. We can give them this option. Those who are credit patients on reimbursements from the government agencies, the ESMO MCBS is yet to be updated since the OS data has not come. So that credit approval would be an issue.
Yeah, agreed. Tejinder, your take? We have Tejinder. Acha, we have Darshit now. Darshit was not there in between, I guess. Darshit? Okay.
Sir,
I
I
think, huh,
sir,
I
I
know you're
think
in the car. Yeah.
Aditya, summarized very well. I agree with him. So, definitely getting the approvals will be difficult when we have a not very strong data. But like in deficient MMRs, definitely we will be going with single agent IO. That's the take on this.
Now, Darshit, which IO you will choose in clinical practice? Pembro, Pembro, durvalumab, very direct question. Huh? Pembro, durvalumab, or if dostarlimab is available, and any reason for prior,
So honestly, sir, I have used Pembro till now, but definitely seeing the data of DOE, I will be more tempted for few of my patients. But as of now, honestly speaking, I have used Pembro for majority of my patients.
Okay. Anuradha, your call. Any particular preference?
So clinical preference is pembrolizumab, but we have started using Durva in one or two of our patients now.
So Durva does has a better PAP than
DMMR groups.
no, whether the patient assistance program is going to dictate the use,
Yeah.
or are you really convinced that these drugs are different? Aditya, your take. Are these drugs different, you feel, in clinical practice? Forget about the data.
Sir, so I have definitely felt that PD-1, PDL1, definitely the class effect is there. Our experience with Pembro is definitely more, but in this study, the ones who were on chemo plus Durva, the side effect profile was pretty good. Except for fatigue, asthenia, there were no major grade 3 or more side effects. So I would be tempted to give a couple of more patients Durva and see how it pans out.
Vaibhav has good experience with Durva in other
Yeah,
diseases also.
yeah. Actually, sir, the thing is here, if you look at the trial, this Pembro, this trial, they actually included patients who had a DFS of 1 year, 12 months. And in this was dostarlimab as well as this Durva study, they had that figure of 6 months. So that might be one of the factors which might factor in, because since we have now the luxury of both the drugs in this setting, otherwise we used to, the Pembro was our go-to drug. But Aditya pointed out very fine thing that in the clinical experience also the side effect profile of Durva just seems to be better than Pembro. I think you would also agree.
Agreed, absolutely, Vaibhav.
Yeah.
So I think a better pay. I mean, I think my take also is that it's a good drug. Little bit underutilized is what we feel, because it all happened because of carpet bombing by Pembro. Honestly, it started as the flag bearer of immunotherapy, then shortly followed by Nivo, and somewhere marketing and many things else. So a lot of data was churned around Nivo and Pembro. But we have now, I think it's a very valid drug. One can consider that, especially the personal experience of side effect profile. I think if the PAP is still, for me, if the PAP is good, Durva will be an option. The whole problem with all these drugs is that now we have Chinese contenders there
Yeah,
in
they
the
are dirt cheap.
market, and whether Indian FDA is giving approval or not, quite a few of us are using in
Sir,
different indications.
I have one question. How do we dose Durva at 11-20 milligram every?
Boibo, your call.
I
You're the
don't do it at that level.
How do we do it? It's possible.
not possible. We give a standard dosing. We don't follow what the DO trial had. Tejinder, your take about the type of immuno agent which you choose. You are the most experienced and senior most oncologist we have in the city of Bombay, after Advani sir and Bowman sir. Tejinder, nothing is exciting. Tejinder is not coming and joining back us. So I think we can move to the next slide. I think we have completed most of the
Yeah, it's
things.
done, sir. It's done.
Yeah. So only thing is that these trials, they did had a 6 to 8 cycles. Some had 10 cycles of chemotherapy. Now, whether that also will have an bearing and impact on the outcome, because classically we are giving 6 cycles of chemo in most of our patients. Aditya, your take on this number of cycles which they have chosen in all these trials, whether it is, NGOT or Ruby.
Sir, I think I'll go with 6 cycles, sir. 6 is a good number.
Yeah, our group of patients, I have not seen, tolerating beyond 6. 6 also becomes difficult sometimes. Last cycle is a modified dose most of the times. Shivam, your take? You're going
Sir,
with
if
beyond?
you go into a CR after the fourth one, I find it very tough to continue even to,
Correct. Correct.
because they develop toxicity later.
Yeah.
They won't show neuropathy immediately. They would show neuropathy after 2-3 months, and it's very long lasting.
Correct. Correct.
Challenge, sir, to
Uh,
eight.
Most of the neuropathy is not reversible, is what my impression is coming now. Over last 7-10 years, I don't know what has happened. Earlier, I used to feel that the neuropathy is reversible, paclitaxel induced. But now, I mean, more and more, I am getting convinced that, some lingering neuropathy is there, and some to worsen after stopping. And as, Shivam rightly said, it starts after 5th, 6th sometimes, when you stop the therapy and the neuropathy sets in and goes on and on. So I think, all these metastatic diseases, quality of life is more important. So I don't feel any compelling reason for pushing 8 cycles, 10 cycles of chemotherapy, and without a very convincing evidence that that really helps. This has been tried in many other tumors, including, ovarian tumors, and there is enough data that giving more is not good always. So I think somewhere we all agree to that. I think we have completed most of the topic today meant to be completed, including pushing durvalumab's significance also. So I think I will thank all the panelists, Dr. Aditya, Dr. Shivam, Dr. Anuradha, Dr. Darshit, Tejinder, for wonderful insight and inputs into this disease. We are very hopeful and fortunate now in this era to practice where we really have good molecules. And, in clinical practice, it's very, very, very gratifying to see patients having a CR. And, it gives a good sense of feeling, which was not seen earlier in endometrial cancer with other chemo agents. So I think with that note, I will thank all of you again and the organizers and hand back the mic to the organizers.